Welcome in, everybody. Thanks for listening to Pharmcast for the Community, sponsored by the University of Georgia's College of Pharmacy. As always, my name is Dr. Tim Brown. I'm going to be your host for the next 40 minutes to an hour as we talk about our upcoming topic for this month, which I'll get to in just a moment. But I want to remind you that in December, I'm actually going to have on someone that works in infectious disease talking about HIV prevention with medications that are now more abundant than ever to stop the transmission of HIV. We're going to talk about access, how they work, and what are your options? And more importantly, who should be thinking about this? And that might surprise a lot of you to realize this isn't just for gay people. It's for a lot of people who are having sex. So we're going to talk about how to get access to those medications and decrease the chance of transmission of HIV. Now, before we get to that, today's talk, however, is on accessing a drug called Naloxone. For those who aren't aware, Naloxone is a drug that's used to reverse narcotics or opioids or things like heroin. And it's become a huge deal in terms of the last decade where we've seen a number of people overdosing. It is pervasive. Every culture, every age group, every tax bracket, it is everything. The problem is, how do you save people who take too much? Well, many states didn't know how to do that. In 2014, Robin, Elliot, and Laurie Fugitt got together with a group of people and really went to work with the legislature to realize that you guys in Georgia need to wake up. And wake up they did. Ladies, welcome in. I know you had a large part in getting legislation passed, and the Georgia Overdose Prevention Act went into effect. I also know this is near and dear to your heart, and you reach out to a lot of people across Georgia over the last, has it been 8 years since you started doing this?
Yeah.
Wow. I think one of the things I want our community to hear about today is, number one, what you guys have accomplished, because it's incredible. The way you've made us in Georgia sort of stand up and take notice that this issue continues to be pervasive throughout all of our lives. And then secondly, how we can help to manage folks in our world and ourselves if we're at risk for taking too much opioids. And we're going to talk about opioids and what that means in a minute, guys. But just quickly, as a pharmacist, I want to break it down and say opioids can be legal and illegal. So legal opioids are like Percocet, OxyContin, Vicodin, even Tylenol number 3 can be a narcotic or is a narcotic. And then, of course, we talk about heroin and fentanyl and those kinds of things that are on the street that we're seeing more and more of. And naloxone reverses all of that. So, Laurie and Robin, I'd like you to sort of tell a little bit about yourselves, if you don't mind, and let you do your introduction. I'll start with Laurie, if you don't mind.
Hi, I'm Laurie Fugitt. I live in Marietta, Georgia. I'm a nurse and a mom and a wife and a Georgia Bulldog, class of 81, go dogs. But I got involved in this because people around me, their children were overdosing, and I just wanted to help. And so now we have this volunteer organization. We provide naloxone across the state of Georgia, and I sort of help in the procurement of the naloxone, getting the kits put together, training distributors who cover the state, who meet up with people who need naloxone and provide it. So that's sort of my role in this organization, and I'm sort of the Narcan lady, I guess.
All right, we're going to talk about that in a second. Hey, Robin, can you tell us a little bit about yourself as well?
Yeah, my name is Robin Elliott. I am a realtor. I have an MBA in finance, and my son Zach died on May 1st, 2011 of a heroin overdose. And as a result of that, I got involved in trying to get a law passed in Georgia and in Georgia overdose prevention.
So you guys did this in 2014 as a team with other people. I do know there were other folks that worked with you on this. Tell me a little bit about Georgia overdose prevention, mission, what it does. And Laurie, you alluded to this a little bit with the kits and access, but I think for folks out there, they probably don't even know this organization exists, but they may have felt its impact and didn't even realize the connection. Who's got that question? Who wants to answer that one?
Yeah, I'll take it. We came together, and we are a grassroots group of people that came together back in 2012, really after Zach died, to try to get a law passed in Georgia. I mean, when Zach died, I knew nothing about harm reduction, had never heard the words harm reduction, but I was through a series of kind of random events I got a call from someone that did know about harm reduction, and they were interested in trying to get a law passed in Georgia. They asked me if I'd be willing to help, and I said I would. And so the four of us some of us knew about harm reduction. I didn't know much of anything. Didn't know anything about getting a law passed. But Laurie joined shortly after that with her friend Susan, and off we went.
Wow. And then I know, Laurie, you and Robin, did you guys meet when you got together for this mission? That was the first time you guys got together, right? So
Right.
that sort of brought you together. And I
Yes.
know both of you because of the impact, Laurie being a nurse and seeing those around her and everything going on. Robin, I know personally, this was an impact in your personal life. It brought you in. Do you guys have, I guess, a territory that you cover as a team? Do you cover all of Georgia? How does Georgia overdose prevention work? Is it anybody who lives within the state? Do you send outside the state? How does that work with this particular organization?
We are not allowed to send our grant funded kits outside of the state of Georgia. We cover the entire state. I've trained 100 people, a lot of them people in recovery or people who have lost loved ones to overdose or healthcare workers. I've trained them to be a trainer and to serve their community. So we have a website. People can write us on our website and say they want a kit. And then I just find the distributor that lives closest to them, and they go out and meet with them and provide the resources they need. Or people can also say they want the kits mailed to them, and then Robin and I do all that. We package it all up and get it all in the mail. So
Okay. So I gave like a little brief overview of what Naloxone does. So you talk about these kits, Laurie. When you say kits, what do you mean? Like, how does Naloxone come? Like when you send out these things and let's say I request it, which by the way, quick question. Do I need a prescription to like ask you for a kit? Or if I have, and we'll talk about who should have this in your house in a second, who should be worried, but you don't, because of this law, right? It now changes it in Georgia. You don't need a prescription in Georgia.
that's correct. You don't need a prescription. You can either contact a harm reduction organization like us or like Atlanta Harm Reduction Coalition and request kits. Or you can, go to any Georgia pharmacy and request a kit. There's something called a standing order, and that basically functions like a prescription for every person in the state of Georgia. So you don't have to have a personal prescription from a physician to go into a pharmacy and buy naloxone. The kits, it depends on the product you're getting. There's several different naloxone products, but basically it's naloxone, whether it's a nasal spray or an injectable, that comes in the kit. There's some literature in there, educational literature. If you've requested fentanyl testing strips, we also put that in there. We usually put a little bracelet that says "Don't run, call 911," and just a card for never use alone and that sort of thing. So, but it's just a very small package that comes in your mailbox.
Got it. So you mentioned something that I think people need to hear. I can walk into a pharmacy and the standing order say, I want naloxone, and it comes as a nasal spray and an injection that goes in the muscle.
Mm-hmm.
It may or may not run through my insurance. I think people need to hear that. Sometimes you may have to pay out of pocket. You may have to run through your insurance. So depends on what's out there. But you guys also have kits that you give out to folks who can't afford it or get access at a pharmacy, right? That's where your kits come in.
Right.
Got it.
We try to focus on what we consider the high risk population.
Okay.
And we would define that as active users, people on medication assisted treatment, anyone that has had a period of abstinence through either recovery or incarceration or lack of funds, or for whatever reason their tolerance level is down. We focus on sex workers, and then we also focus on all the loved ones or people that are regularly with those people, because though you can't administer naloxone to yourself.
Yeah.
We need to make sure the people that will be with those people are available to have naloxone on hand to hopefully save someone's life.
Well, and now that's a good point, Robin. I mean, it's as much as this is about the person that's using or relapsing, or when you talk about medication assistance therapy, those on Suboxone and those
Yes.
kinds of therapies. And you said this earlier, like they've been off for a long time, they've done really well, and then like anything else, you can relapse. Giving it to them is awesome, But if something happens, it's the people in their orbit, in their world, that need to know where it's located or need to have their own, right? So
Yes,
I see
and we
that.
always recommend that those people to make sure that everybody in their orbit knows where it is, how to use it. It's very simple to use, but we just like to make sure that everybody knows where it is, because we've had multiple situations where there was naloxone on site,
Yeah.
but people didn't know it was there, and the
Oh
person
gosh.
died.
Oh, that
And
would.
that's even at treatment facilities that's happened. So it's so important for people to know where it is, how to use it, and just be ready to go. You know, time is it's a very time sensitive issue.
Yeah, no, makes sense. And Laurie, I want to talk about how to use it and that time sensitivity. I know as a nurse, you do a little bit about this, but we've talked about the fact it's a shot, it's a nasal spray. Which one is the most common that people get? Is it kind of 50-50, or is one cheaper than the other? How does that work?
I mean, for our particular organization right now, we give out more of the nasal spray than the injection, but
okay, I have to admit, when you say nasal spray, I think to myself, if I'm passed out on the ground because I've taken too much, how do I sniffle a drug? How do I make it do its thing?
you don't. It's absorbed when. Okay, so if you see somebody that you think is overdosing, okay, you may notice the signs and symptoms of overdosing, but basically we want you to not go through a head to toe assessment, just determine if this person is unresponsive. That's the key word in all of this. Unresponsiveness. And the way to do that, I made up this little thing called the 3 S's. So you're going to shake their shoulder. You're going to shout at them, hey, wake up, wake up. Are you okay? I'm going to Narcan you. Sometimes that'll snap them right out of it. And the 3rd S is sternal rub, the breastbone, the sternum. So you're going to get your knuckles and you're going to rub really hard up and down their sternum. If they don't react to that, because that causes excruciating pain if you do it hard enough, they don't react to the sound of your voice, your touch, and pain, then you're going to give them naloxone. And the way you do it is you simply get them flat on their back on a hard surface. Got to have them on a hard surface, not a soft surface. Okay, because chest compressions don't work on soft surfaces. Get them on a hard surface. Tilt their head back. Key. You tilt their head back because it opens up the airway. It also lets you pull the chin down, look in their mouth, and if there's any foreign objects in there, you can remove them, like fentanyl patches that people cheek. They put them inside their cheek to absorb the last little bit of medication. Maybe they've still got a mouthful of pills. Maybe they've got a syringe cap. So you're going to want to clear that out. And then the 3rd reason you've got that head tilted back is the way this nasal spray works is you open up the container, you take it out, it's ready to use, no cap. You just put your finger on the plunger and you put it up a nostril as far as it'll go, and you depress the plunger. And the way it works is not from the person magically waking up and going, well, you know, like you might Afrin. It works by having this fluid, this naloxone, sitting inside the nose and being absorbed by all those little capillaries that are in your nasal tissue. So you got to have that head tilted back so the medicine doesn't run out, or you know, then it won't have a chance to work.
So is it just one dose, or like on one side?
Yeah, it's just one dose. You just push this all the way up and it gives one dose up one side of the nostril, or then if you're given more than one dose every 2 minutes, you can redose. Then you go up the other side and you just go back and forth.
So are there 2 doses in that, Robin? I'm sorry, Laurie, or is there just 1 dose in that?
And when you get a box of Narcan, like nasal spray, or the newer that's out, there's a new one out now called Cloxado. They both come with two doses, 2 individual units, but per unit is 1 dose. The Narcan nasal spray is a 4 milligram product per dose. The Cloxado is 8, so it's double the strength. And then you've got injectables like the good old-fashioned vials that we have.
Before we go to the injectable, though, like the nasal spray, I give that one on the side, and you said wait 2 minutes. If they don't respond, like they don't wake up, that's when I should give them another dose on the other side and keep doing that if they don't wake up?
Yes, but after you give the dose, that's when you then call 911. Okay.
Got it.
Because you want to get this on board first to let it start pulling those opioid molecules off the receptor cells in your central nervous system that affect your breathing. Naloxone blocks those receptors. Those receptors like naloxone better than opioids. So if those receptors are covered with opioids and you get naloxone in their body, the naloxone basically rips those opioids off of those receptor sites, and then they just sit there because naloxone isn't a respiratory depressant like opioids are. And so that's when a person can start, breathing again. But you're going to call 911, tell them that you are with an unresponsive person. Don't say overdose, because if you say overdose, 911 protocol is that they have to call law enforcement to the scene to secure the scene. You don't want that time wasted. You want someone showing up that has naloxone, and EMS is going to have naloxone in Georgia compared to the police. Not every police department or sheriff's department has it.
Yeah.
So yeah, and then every 2 minutes you redose, every 2 minutes,
Okay.
whether you're given a shot in the arm or the upper outer thighs, or whether you're spraying.
So I know you're getting ready to talk about that shot and the nasal spray. The nasal spray actually sounds real easy to do. Like, I think if I were nervous, I could do that a little easier. But there's a shot available as well. And you held up the little vial, which scares the hell out of me because I'm not so sure I'd be able to hold that while I'm shaking, trying to pull up drug. Does it come prepackaged, or how does it come?
There's both. Okay. So the old-fashioned one, the one we've been using since this community naloxone has been using this since 1996. Naloxone's been around since FDA approved it in 1971. So it's a very safe, effective, researched medication. The old-fashioned way is you have these vials, you just pop the orange top off, take your intramuscular syringe. You can set this on the table, and the needles are so long, you can just stab it through the little rubber stopper and then pull the plunger up and get all the liquid into your syringe. But there's a new product. The new product is called Zimhigh, and it is a preloaded syringe-like unit. It's not just a syringe, it's kind of like a little machine. And with that one, it's actually, this is 0.4 milligrams. The Zimhigh is 5 milligrams. So it's 12 and a half times the dosage of this, which harm reduction people like Robin and I are not sure that's a great idea. But anyway, and with that unit, you just screw off the cap over the needle, put the needle in the upper outer thigh, depress the plunger until it clicks you leave it there for 2 seconds. And then you remove it, put the safety lock down over the needle, and put it back in its case. So,
but Tim, to kind of respond, I mean, I think that we have found exactly what you said. So we tend to give out the vials and syringes to healthcare workers and to people who are really comfortable using needles, like active users of injectable drugs. We'll give them out to anybody that asks for them, but most people that are not in those two groups prefer to get the nasal.
Yeah, I just was thinking and I know you guys do a lot of kits, which I love, but I'm thinking if I walked into the pharmacy and I'm in that orbit of someone I love, and they tell me the price of some of these products, I may be forced to look at the vials and the syringes because it's the cheapest way to get this. And Laurie said this earlier, this is a muscle. It's not like a little prick. It goes into the muscle. And I know, Laurie, you like the upper arm, right?
Yeah, the deltoid, where people get vaccines.
Yeah, because a lot of times when I've been reading, they're like, stab them in the thigh, just stab that through the clothes and everything. And you can still stab them through the clothes on the arm too, right?
Yeah, it actually absorbs faster out of the deltoid. So I just usually recommend the deltoid, but you may be given more than one dose. So you may do a deltoid, then you may end up hitting the thighs too. So
it's interesting because working in healthcare, I've seen some people who've been using narcotics for a while and they don't have a lot of muscle left on them. So sometimes I tell people hit the bigger muscle. That way you don't miss. So, like into the leg or the arm, but never in the butt, right? You never put it in the butt.
Too much fat there.
Yeah. Never put it in the cheeks, guys. I mean, because I think when we were kids, right, when I was sick, I used to get penicillin shots and they always went to like the cheek. Well, this doesn't work there. It's got to be the leg or the arm. And don't worry about clothes. Stick it straight through because I think Robin said this, time is crucial here, right?
Yeah, time is tissue. You're losing tissue. You're using function.
So let's say I
so
save my money, I pop in the pharmacy and I pick up naloxone nasal spray because it's not cheap. I mean, but it's not, I mean, and the expiration date says 2025. I have, 2025, I've got 2 years to keep this around. I never have to use it. By the grace of goodness, everybody's doing great in my family. Do I throw it away at the expiration date?
no.
Please, no.
Oh, really? That's
No.
great. And so
The,
it
the
lasts
latest
longer?
the latest research shows that it lasts minimally 25 years past that printed expiration date. Most doctors think it never expires. It's still, they've done all sorts of testing. It still meets the what's called USP, United States, I think it's pharmacopoeia standards,
Yeah.
of which means it's still at least 90% pure naloxone in the container. So it's still going to work. So we have hundreds and hundreds and hundreds of reports back to us of reversals people have done from kits we gave out in like 2014, and now it's 2022. Wow. Yeah. So if you got it, use it. Don't throw it away. If you feel like you must get rid of it, get it back to us.
Yeah.
Got it. That's actually a good point then. That means that, obviously I buy it. If I don't use it, I've got it around. So I can certainly keep that. If one dose of my nasal spray works, I can keep the second dose for something later. Mm-hmm. It's interesting because as pharmacists, we teach the fact that you give a dose, they wake up. If they're on a long-acting narcotic, they may fall back non-responsive again. So don't be afraid to give them another dose and another dose until the EMS get there, right?
Right. Naloxone tends to last about 30 to 90 minutes. Yeah. And after that time, the opioids still in the bloodstream usually are able to reattach to those receptors, and the person can fall out without taking any more drugs. So we encourage people to try to get your friends to accept medical transport after an overdose. When you've made that 911 call and EMS comes up, try to get them to go to the hospital with EMS. But if they won't, then please stay with them. We say 6 to 8 hours, hoping we get 2 or 3 hours. So
I think people are scared of the law too. I mean, they're like, do you get into trouble? Like, let's say I do your 3 S's. This is a stranger, and I just happen to keep naloxone in my bag, which I do. And I give it to the person. Can I get into trouble just for randomly giving naloxone to some person that's unresponsive on the street?
Actually, what our law says is that any doctor can prescribe it, any pharmacist can dispense it, and any resident of Georgia can obtain it and administer it without any risk of civil, criminal, or professional licensing liability for doing so. We absolutely not. You cannot get in trouble, and it just has to be a suspected overdose. The person doesn't actually have to be overdosing.
Yeah, because you don't have any idea, right? I mean, if you find somebody responsive and you think that might be what's going on, I get it. I just sort of think people are like, oh my God, I don't know what I'm getting into. It's kind of scary. But it's funny because teaching for the number of years I have now, there are so many students at UGA and other places that carry naloxone with them, not necessarily because of themselves, but for their friends. They've gotten access to it. They know what their friends do on the weekends and at night. And I guess during the day too. Here I am being like, it only happens at night. But I like the fact that some people are kind of being preventive for those folks in their world, if that makes sense.
Well, we actually try to tell people, as I said before, we try to focus our kits on high-risk people.
Yeah.
But we hope that everyone that can will have a naloxone kit, because we have so many reports of stranger reversals, people that are just walking along and they see somebody and they happen to be proactive. They have naloxone with them and they're able to save someone's life. So, I mean, the odds are probably slim, but boy, I'd sure rather be protected and be able to help than not.
It's funny you said that, Robin, because I was reading an article before this, and they're increasing the amount of money. President Biden has decided to increase how much he's putting into the policy task force to look at drugs in the community and also how to get more access to naloxone or Narcan, which is the drug we're talking about. Like, he was going to increase spending this year by like $32 billion. It's weighted out in grants and stuff. But the statistic that caught me was our nation is facing 108,000 overdose deaths in just 12 months that we know of. That is one life lost every 5 minutes around the clock.
Mhm.
And so it's not just people who are using drugs from the street. It's
Right.
not people who are, I want to be really clear here. This is every population, every tax bracket, every ethnicity has been impacted by this. Is that why you guys feel community access is so important? I mean, it seems like a stupid question I'm asking, but I'm just trying to reinforce you guys are helping people from all walks of life on all kinds of drugs. Is that not fair, Robin?
Yeah, well, I mean, it's really important for people, specifically for anybody that's getting a prescription for any kind of opiate,
Yeah.
in my opinion, to get a prescription, to get a naloxone kit from your pharmacy at the same time, because for a variety of reasons. But just think of grandpa who has taken his medication, and then his grandson comes over and says, "Pop, did you take your medication?" And grandpa doesn't remember, so they give it to him again. And the next thing you know, he's in trouble. Also think of diversion, because people who are getting an opiate prescription can have that opiate in their medicine cabinet, and somebody else in their family or elsewhere can divert those drugs and take them in a larger quantity, resulting in an overdose. So there's so many avenues of risk. It's not just street people that are using street drugs.
Right. And so it's interesting because I actually read another statistic. You would think all I do is read statistics, but it talked about a lot of times the first narcotic that someone tried was in the medicine cabinet of a relative.
Right.
And they gained access to it. So I remember having my wisdom teeth out and being given Vicodin. And I think I used 3 of them and put the rest of them in the cupboard because my mother goes, we may need these later. We'll put these
Yeah.
away. And so it's interesting because that means it was there for my brother who's in the house or whomever. But I guess the other side of that coin that you point out is, let's say I had hip surgery and I start taking Vicodin to go through rehab, or I didn't get the surgery and my hip hurts all the time, so I take Percocet every day. You're saying that I should have naloxone in my house, or at least my relatives should know to have naloxone or where it's at in my house, right?
Right. Cancer patients, anybody post-surgical that has pain meds, definitely you all should have, there should be naloxone around. And you know what, unfortunately happens a lot of times is people are given a script, but then, a lot of things have happened to make it very difficult for chronic pain patients who need medication for their pain to be able to get it. And so sometimes they are forced to get something off the street. And unfortunately, now in Georgia, almost every single type of medication or drug that's on the street has been found to have fentanyl or fentanyl analog in it, almost every single type. So it's not just people who are taking opiates. It may be somebody who thinks they're taking a Valium or some other kind of benzodiazepine or any variety of drugs, Molly, anything out there. Fentanyl has, contaminated, been laced or, maybe just contamination in the processing has gotten into the drug supply big time. So
I mean, we had somebody recently in Atlanta that, I mean, I don't mean this to say this sort of casually, but he was he was in the movie industry. He snorted cocaine recreationally. It was cut with fentanyl, and he overdosed, was taken to the emergency room. It was the middle of COVID. They released him after 2 hours and didn't keep him. And when he got home, he died.
Yeah,
So
it's interesting you guys bring this up because I've read a lot of stories that are stories out there in the media and vice versa, where someone thinks they're taking something that's not an opioid. It's a benzodiazepine, it's an upper, it's a downer, it's alcohol, and vaping, THC. I've read articles where there's been THC that's been cut with a fentanyl, and so while THC is certainly not in this category and will not be reversed by Narcan, if fentanyl's inside of it or inside the cocaine, it can bring somebody back. So it's better to give naloxone regardless of what you think they may have taken, right?
that's what we always say. Even if they say, "Oh, don't give it to that person, they only take meth," there's no way that's going to work. Give it to them anyway, because it won't do anything about the meth, but it will reverse any opiate that's on board.
Yeah. That makes
and usually those THCs that's coming from law enforcement, and that has not been proven. There's a difference in burn temps, and that's why fentanyl will not affect somebody if it even was in marijuana. But That's really not a thing to worry about. There's legitimate things to worry about out there.
Yeah, kind of worry about everything else though.
Yeah. Okay. Yeah. Well, and
Yeah.
it's the reason I'm asking these questions because I think about my dad and my brother when my nephew's around, and like, not that my nephew is out there doing this or that. It's just I think to myself, should we put this in the house just in case friends are over, things do happen, people experiment, whatever. And then
There's so many avenues to this. A friend of mine had a knee replacement,
yeah.
and she's 85 years old, and the doctor gave her 100 pain pills.
Wow.
She took 3.
Yeah.
She
Yeah.
had 97 left. And all I said to her was, thank God you don't have a teenager living in your house.
Yeah.
And
That's
not to say that every teenager is going to do that, but like, as you said, frequently that's the first avenue that they take to, and she had 97. I mean, so there's a lot of ways that things could make the situation better, but certainly everybody with a prescription to an opiate should have Narcan or Naloxone in the house.
okay.
And the wonderful thing is if you do come upon a scene, maybe you go in the bathroom at Starbucks and there's someone laid out in the bathroom, you don't know that they're necessarily overdosing, but they're unresponsive. So you give them Narcan, but let's say it turns out they had a heart attack or they're in a diabetic coma. Maybe they're, caramel macchiato, send them over the edge or something. It's the naloxone's not going to hurt them, and you're protected legally from giving it. I mean, it may raise their blood pressure a little bit, just for that, hour or so, but it is not going to hurt them. So it is fine to give naloxone to people. Like Robin said, you just have to suspect that they may be overdosing.
Right. And then of course, knowing that, call the 911, put your dosing in, and then start CPR and resuscitation if you need to.
Right. They'll talk you through all that.
Yeah.
And this little box too on the Narcan nasal, even when you open up the front of it, which I think some people aren't aware that happened, there are the instructions right there.
Got it.
So easy breezy. You don't have to have this whole process memorized. And really, if the only thing you do is tilt someone's head back to open up their airway, clear out their mouth, and then either give them the injection or the spray, you've probably just saved a life. I mean, it's not a complicated thing. So
I think, Robin, I also want to ask a little bit. I mean, Zach, in your world, Zach was how old when he passed away?
Zach was 21.
And you knew that he had a history, right?
Well, yeah, Zach was, he was a great kid, went to private school, was really smart, played piano, guitar, everything, just like, but I'm in long-term recovery from alcohol. So Zach had a familial history of substance use disorder, more than just myself, but also a long list of relatives. He also had a childhood tragedy. I mean, his father, my husband, died when Zach was 4. So he had childhood trauma. Very against drugs, 16 years old. I went to a party, kids were smoking marijuana. He called me, come pick me up, Mom, don't want to get involved. The very next party he went to, the kids were smoking. He thought, well, I'll try it. And within 3 months, Zach had tried every drug there was to try.
Mm. And then at the time, naloxone wasn't available, right?
At that time, you could find naloxone in a surgical suite, on the surgical floor of a hospital, in an emergency room, and if you were lucky, on an ambulance. But the police didn't even have it, and frequently they were first on scene. And certainly no individuals could have it. I mean, there was no way to get it. It wasn't available, period. And that's really what our law did, was it made this life-saving drug. It put it in the hands of people that need it.
Around folks that when something does happen, they're the ones around when it occurs.
Yes. And as we said so many times, time is the issue. So if you're waiting, and this happened to so many friends of mine's children, they waited for the ambulance to get there, and the ambulance either had or didn't have naloxone on board. And by the time the ambulance got there, they had died, or by the time they got them back to the emergency room, they had died. But now the person on scene can start that process of getting the opioids pulled off the receptors before 911 gets there, before the responders get there, to sort of start the process going. So, and maybe, certainly sometimes the person just sits up and takes a breath and they're back. So, it's invaluable, and lives are being saved all the time.
And no one's giving naloxone to themselves. If you can do that, then you don't really need naloxone.
That's a fair point.
It's critically important that the people, frequently nearby a high-risk person are the ones that, have it. We try to kind of make a little safety bubble around. If someone tells us, my child has overdosed twice in the last 3 months. We not only give kits to the parents if they're divorced, 2 of them to each one,
Right.
then to the person, we want the person who's at risk to have it. And because we want that person to tell all their friends, maybe people they use with, that they have it and how to use it. And then, maybe, sometimes we get employers that write us, who know that they have employees that use, so we try to kind of make a little safety net of naloxone around high risk, users.
I know some of the places here on campus have put it in their residence halls or their dorms or their houses because they're thinking ahead. It's interesting because of my interaction with you guys, I've actually put it at the medical college and not necessarily because I think there's this huge need here or there, but I want the students to be aware that they have access to it in case something happens on campus and what to do with it. And I don't know, what you've done is you've created an access point in the state of Georgia for all citizens that live or touch someone that could be using a narcotic. And that, by definition, is a lot of people. And I want to thank you guys so much for all the work you've done and everything getting this through. I think the other thing I really want to ask of you, though, for our audience, we've talked about a lot. Can you give me 3 pearls that you would give your audience so they don't forget some of the things we've talked about, if you don't mind? Laurie, I'll ask you to go first. Can you give us your 3 pearls?
Well, I guess Robin actually wrote up the 3 pearls. My main pearl is the establish unresponsiveness. Use the word unresponsive when you call 911. Just remember that word unresponsive.
That's a good one.
That's critical to getting quick response.
Good. Yeah, I like that.
Robin actually wrote out 3 pearls. So
my first one is just, if you have anybody in your life that is at high risk through either street drugs or through a prescription opioid, please keep naloxone on hand. Make sure it's easily available and that everyone is trained on how to use it. And a training video is available on our website so that you can get the full training of how to use naloxone.
What's the website? Because where would they go? What's the name of it?
It's Georgia spelled out, overdoseprevention.org.
Okay, and you can Google that too, or I'll Google it and it's taking me straight there. You guys have that, and I know you have other things that you put out around the state for people to watch, but that training video, I think Laurie is the one that runs us through how to inject, how to do the nasal spray.
Yes.
So if you don't get that here today with our Farmcast, pop over there and watch that. And I think, Laurie, you opened that little pouch, that little packet up and showed us the thing. I love those pictures because I don't know how you are, but I can't read that print because I'm old. Mm-hmm. So I don't have time to find my readers if I'm trying to save this person. So I love the pictures as well. And that video's there is good. What else did you have, Robin, to remind us of?
Well, another part of our law is about don't run, call 911. So I just have don't run, call 911. Dead people don't recover. So just please know that where there's life, there's hope. Our mission at Georgia Overdose Prevention is to keep people alive, and you can be part of that mission as well.
Thank you so much. You guys do so much for our state. I want to send our thank you to you. For those who don't know this, these ladies are actually our keynote speaker here at UGA when we do an interprofessional event involving nursing, physicians, medical students, pharmacy students, and those from social work, the School of Social Work students. And they talk about this and they give their story, but they also do a training. I know they said they have taught 100 people to be trainers, but you don't realize the number of people they've taught how to use naloxone in this state through their videos. It is in the thousands. So I want to say thank you so much for all the work you did, not only for the legislation, but for what you do after the legislation was passed. Thank you so much for joining me here on Farmcast for the Community.
Thank you, Tim. Always a pleasure.
Wonderful.
Thank you so much, Tim.
Absolutely. And guys, please stay tuned for December's issue coming up. We'll be talking about PrEP, which is reducing the transmission of HIV. We'll be back with you in December. My name is Dr. Tim Brown, representing UGA College of Pharmacy's Farmcast for the Community. As always, stay healthy. We'll see you in a month.